Welcome, everyone, to the Canadian Nurses Association webinar series, Progress in Practice. CNA has partnered with Community Health Nurses of Canada, Community Health Nurses Leadership Institute, in a series of webinars to support the leadership development of public health nurses. This is the first of 3 webinars planned. The second webinar is on Thursday, January 25th, and then the third one will be planned in February. This webinar is titled Leadership Competencies for Public Health Practice and Leads Capabilities. This session is being recorded for nurses who are unable to participate today. My name is Ruth Schofield, and I am an assistant professor at McMaster University and the CHNC Community Health Nursing Leadership Institute Chair. I will be moderating this webinar. At the end of the presentation, we will answer your questions, which you can type in the Q&A box that you see to the right of the slide. We will address as many questions as time allows. As you'll notice on this slide, if you want access to follow with the competencies, you will note in the web links below access to CHNC website. And if you go on there, you'll be able to have access to the competencies if you don't have a hard copy in front of you. Select publication/resources from the top ribbon, and then scroll down as it indicates to find the document, and you will select PDF. It is read-only. Then you'll see you can go to page 10 to 11 on the PDF for the list of the competencies. So page 4 to 5 is if you have a print copy. And for those of you who may not have the document, you can purchase it at CHNC if you wish. Likewise, you will notice that you can download the Organizational Readiness for Change tool on the CHNC website, and that is also under, I think, publications, and you can download it there. And now, a little bit about our presenters, Ardene Vollman and Brenda Lammi. Ardene Vollman is the academic partner to the Community Health Nurses of Canada for the Leadership Competencies Project. She has demonstrated track record in public health research and has served in leadership positions in public health advocacy, administration, education, and practice. She is also an adjunct professor in the Department of Community Health Sciences at the University of Calgary's Cumming School of Medicine. Brenda has been the director of Leads Canada at the Canadian College of Health Leaders since 2013. In this capacity, Brenda develops partnerships to exceed expectations and ensure the delivery of best practice leadership development and leads integration services for health organizations and authorities across Canada. And now over to Ardene to start the presentation.
Thank you, Ruth, and welcome everyone. I hope you can hear me well enough. Let me begin by explaining my role on this leadership project. I was contracted by the Community Health Nurses of Canada and their partners, the Canadian Institute for Public Health Inspectors and the Manitoba Public Health Managers Network, to carry out the environmental scan that would support the development of leadership competencies in public health in Canada. As academic partner, I and my colleagues were responsible for ensuring the rigor of the research conducted for the scan and for the process for determining the competencies. In this presentation, I'll briefly describe the process and then turn the webinar over to Brenda Lammi, who will discuss leads in detail. I'll also, near the end of my presentation, do a quick comparison of the competencies with the leads capabilities. And I do encourage you to download the competencies if you can. So in terms of background, there was a general opinion that over time, leadership in public health was declining and needed bolstering. Each of the discipline-specific competencies, as well as the core competencies themselves, had leadership as one of the key competencies. The community health nursing partners put forward a proposal to flesh out what leadership in public health in Canada meant, and were funded by the Public Health Agency to develop specific competencies to support leadership development for public health practice. On this slide, you can see the 7 public health disciplines. So over a 3-year period, beginning in 2013, the academic partner team conducted a rigorous scan to support the competency development. You can see what that scan comprised by this slide. The first thing we did was a scoping literature review that resulted in 363 scholarly articles being retained, and of those, 139 were from public health. Also, gray and supplementary literature supplied an additional 68 citations. On this slide, you can see that over 80% of the literature came from the US, the UK, Canada, and Australia. We found from the literature review that there is an ambiguity in language, specifically between leadership and management, and also the terminology such as competencies, capacities, capabilities, or characteristics. Further, the outcome of public health leadership was unclear in the literature. Indicators of successful public health programs, however, are related to what can be measured, such as vaccination rates, for example. We also found that there's a strong drive toward transformational leadership in the literature, and critical competencies for transformational public health leaders include such things as cognitive skills, communication, crisis management, negotiation and collaboration and teamwork, as well as relational and group capacity building skills. We then conducted an online survey of the 7 disciplines engaged in this project and asked respondents to rank the qualities of leaders, the knowledge, skills, attitudes, and behaviors that we found from the literature review, and including barriers and enablers to successful leadership. The 10 most common characteristics identified in the literature review for each of those categories were included in the survey, and 821 public health workers from across Canada responded to the survey. So a good response rate. All public health disciplines, you can see from this slide, were represented, with inspectors and nurses comprising just over half the sample. And this is similar to the representation of the disciplines in practice. The characteristics of the respondents, there was fairly even breakdown in experience level. Most of the respondents were frontline service providers, and over half, not surprisingly, were from Ontario. So what did we learn from the survey? From the 10 items in the survey, we retained the top 5 knowledge areas, which you'll see listed on the slide, top 5 skill sets, and the top 5 positive behaviors. These formed the basis for the next steps in the environmental scan. And what did we learn from the survey? Well, it confirmed what we knew about the conflation of the terms management and leadership. Also, feedback from the comments indicated there were challenges to how and what people thought about leaders and leadership. And the notion of a team as a leader was introduced by the survey participants in their comments. The next step was to conduct focus group interviews with people nominated by the 7 public health disciplines as being recognized as leaders in public health. Again, all the disciplines were represented in the sample, and the bulk of those interviewed were in upper management positions in their public health agencies. So we began with the top 5 identified in the survey of knowledge, skills, and behaviors, and asked participants to add or delete from that list. And yes, the 30% response rate might have been seen as disappointing, but it's not uncommon in social science research to get low response rates for focus groups. And the focus groups did take place over the summer months, which also affected the response rate, but we were able to achieve saturation as we analyzed the results. So, not surprisingly, the people from the webinars added several items, but interestingly, a significant amount of time was spent discussing barriers to exercising leadership in public health organizations in Canada. Barriers, personal barriers, organizational barriers, and high-level macro system barriers were all pointed out. So with reference to the results of the environmental scan, over 50 statements were proposed to begin the Delphi process. And for this part of the research, a survey was designed, approved by the University of Calgary Ethics Board, and then pilot tested. The results of the Delphi are illustrated on this slide. It took 3 rounds to reach consensus, which was set at 80% of agreement among the Delphi panelists. Round 1, 42 of the statements were adopted. In round 1, 42. Round 2, further 6. And then finally in round 3, the final competency statement achieved consensus. So we ended up with 49 agreed upon competency statements, but the framework with which the project began, that is the knowledge, skills, attitudes, and behaviors, wasn't robust enough to present the competency statements in an easy to understand or use manner. So after further review, the Leads in a Caring Environment framework was adopted to present the 49 statements. However, several differences between the competencies and leads are apparent. The order is different. The competencies don't have category or domain descriptions. The competencies are numbered, implying a hierarchy. And then there is that language difference, competencies versus capabilities. But otherwise, the framework served as an excellent way to present the competencies so that they could be understood not only by public health, but also by others in the health system and externally. LEADS has been widely adopted in Canada, and by using the same language of leadership as others, it was hoped that there would be better communication between and among public health and others. So I'll now briefly describe the fit of the competencies with each of the LEADS domains. in the order used by the leadership project and the competency document. So in the domain of systems transformation, there is excellent overlap between the two sets of competencies and capabilities. The leadership project concept of adapting is not directly reflected in the LEAD's language. This difference may highlight the power imbalance between the illness care system and public health. Perhaps leaders in acute care have more social capacity to enact change through challenge, whereas public health leaders may have to resort to enacting change from within. This interpretation is supported by feedback we received during the Delphi process. The panelists referred to the ability to adapt as a matter of survival. The domain achieve results reflects the ongoing expectation that public health leaders are strong advocates for the field of public and population health and health equity, as reflected in Competency 2.5, which is unique to the Leadership Project. There's some overlap with LEAD's developed coalitions, specifically 2.1 and 2.4, and this might reflect the different conceptualization of results. In public health, it means the upstream policy changes that are necessary to improve population health and health equity. And this is certainly informed by the awareness that public health outcomes are impacted at the policy level, not by the personal achievements of individuals. The Leadership Project has treated lead self in terms of how leaders acknowledge their professional practice within the health system and society. This is in contrast with LEADS that considers it in terms of how leaders maintain their self-motivation. 3.1 explicitly refers to external principles such as discipline-specific ethical codes rather than personal ethical principles as guides for action. The lead self domain in the Leadership Project refers to the use of evidence-informed decision-making, whereas the reference to evidence-informed decision-making in LEADS is found under Achieve Results. Nevertheless, it does make sense to have it here in LEAD Self because our focus group participants described the need to demonstrate their credibility to others by offering evidence to support the positions that they advocate. You can see that the Leadership Project has 4 times the competencies in this domain than LEADS. Public health leaders, of course, recognize the need for engaging stakeholders from a variety of backgrounds, recognizing that public health has relevance to many other sectors, and that other sectors too have the potential to impact population health and public health outcomes. Therefore, 4.2, transdisciplinary understanding, 4.10, power sharing, and 4.11, employing a variety of decision-making styles, are necessary to address the context wherein public health operates. And several of the Leadership Project competencies indicate awareness of the political arenas in which public health leaders must operate and navigate. Those specifically are 4.14 to 4.17. Interesting, the Leadership Project is silent on the notion of team building, where LEADS is very explicit about it. The public health sector depends on its relationships, partnerships, and coalitions with other stakeholders in and outside of the health system to achieve its strategic goals, population health and health equity. So rather than the LEAD's concept of customer service, success in public health is measured by improved population health status and health behaviors and the adoption of healthy public policy. The lack of awareness and understanding of public health by the public and other health and social sectors are reflected in Competencies 5.7 to 5.9. It's interesting that in LEADS, the capability of leaders to navigate socio-political environments and negotiate through conflict is identified, whereas conflict is never mentioned nor implied in the leadership competencies. So perhaps the closest would be in the leadership project Engage Others 4.15, which is to have effective mediation skills. I guess we're conflict avoiders. So in my concluding comments, LEAD provides a robust framework. There is excellent agreement of the competency statements with the capabilities among all domains. Both LEADS and the leadership project agree that leadership occurs at all levels, and the slight difference of definitions of leadership. LEADS defines leadership as the capacity to influence self and others, and the public health agency definition, influence, motivate, and enable others, no mention of self, isn't problematic in the larger scope of things. So the next steps, what's next for the leadership competencies for public health practice in Canada? Well, steps are underway to foster the adoption of the competencies across Canada. They were released in June of 2015, so it's early days yet. But a leadership network has been created. A knowledge translation plan is in place, as is a readiness for change tool, with the hopes that in time the competencies will be adopted widely across the country. So for more information, all reports and documents are available on the CHNC website, and I encourage you to read them if you're interested in public health leadership. And I'll turn the presentation over to you, Brenda, to describe LEADS in more detail. Thanks.
Great. Thank you, Ardene. This is Brenda. Good afternoon, everybody. Thanks so much for joining in this afternoon. I am going to speak about LEADS in Canada and who's using it, a little bit of the background, the overview. Where did LEADS come from? What's the evidence? What's the theory supporting the framework? And then who's using it across Canada? So starting out in British Columbia about 10 years ago, there was an observation that there was a gap in health leadership. And when you looked more broadly across the country, that gap was evident. There was they did some pilot and focus group studies, and there really was a gap that was existing. So the province of British Columbia, the government, funded Royal Roads University to develop a leadership framework specifically for healthcare, which is actually unique to the world and still is, having been designed specifically for healthcare. So Royal Roads, the research team led by Dr. Graham Dixon, looked at over 120 leadership frameworks from different sectors and pulled out the pieces that were relevant between them all, and then looked at them through a healthcare lens. So and it started out just being called LEADS, and then they did a validation study across Canada. It was funded by the Canadian Foundation for Healthcare Improvement. It had a different name back then, but it always escapes me. So they validated it across Canada, and that's when the title added the in a caring environment piece, because it really wanted to set itself apart from other frameworks in other sectors. Because the concept of LEADS, and that's what I'll call it, I'm not going to use the full title, the concept of LEADS is that we're all in this together. We're all looking at excellent patient care, excellent patient outcomes, the best possible processes, and not all sectors can say the same thing. You know, those that are looking to make money, those are, you know, there's different priorities, but our priority, no matter what area you work in healthcare, is the patients and the clients and the people that we serve. Nobody wants people to wait longer. Nobody wants people to be, you know, more ill or not get the best possible care at the time. So we do have that shared vision. So LEADS in a Caring Environment was then adopted by the Canadian College of Health Leaders, Healthcare Leaders Association of British Columbia, and the Canadian Health Leaders Network. And through that adoption, there was an endorsement of the framework. So the members of CHLNet, which includes the Canadian Medical Association, Blood, and amongst others. There's 42 health organizations there that are members of CHLNet, plus the members of CCHL. So if you go towards your Certified Health Executive certification, that is LEADS-based knowledge development. So that's where LEADS came from. A quick overview of LEADS. There's 5 domains, LEADS, and I'll get into what those stand for in just a couple of slides, but keeping to the overview level, there's 4 capabilities per domain. And these are based on the evidence, and they're very high level. And then for each of those 4 capabilities, there's a set of behaviors. So each capability has 3 behaviors that demonstrates that capability in practice. What does it look like to be, you know, X, whatever that capability is, when you're in practice? So it's very functional and it's very observable. And there are 4 sets of behavioral descriptors so that it reflects your level of leadership within the organization. Are you at point of care or are you a senior executive? Because the capabilities are going to look different depending on what level of leadership you are within your organization. So the 5 domains: leading self, engaging others, achieving results, developing coalitions, and systems transformation. So the first 3, leading self, engaging others, achieve results, are quite consistent amongst most leadership frameworks. We had an actual little literature review done through a master's student at McGill University, and compared our domains to those of others, and they found the LEA are pretty consistent. It's the develop coalitions and systems transformation pieces that really set LEADS apart from others. And that's that shared vision of we're ultimately working together for system improvement with the patient and client in mind. And then developing coalitions is prioritizing how we can work together because we have that shared vision. So the D and the S in LEADS really sets LEADS apart from other leadership frameworks. And we're finding that actually beyond healthcare, the public sector is looking at adopting in different areas the framework as well, because it does speak to public service as well. So I then mentioned a little bit about the different in language, and this is how here, you know, through LEADS lens, this is how we define the difference between capabilities and competencies. So capabilities, as far as the LEADS framework is concerned, is the art of leadership. It's what does it look like for you as an individual, as a leader within your organization. What's your leadership style? It's going to be different depending on who you are and what your strengths are. Competencies, again through the LEADS lens, are the black and white skills. They're going to look the same regardless of who you are. They're scientific, they're prescriptive, they are the black and white. They're the science. So capabilities is the art of leadership, competencies is the science of leadership. So digging a little bit into the framework itself, we have the achieve results starting in the middle, and this is the most competency-based domain that we have. This is where, in my mind, this is where the competencies fit. And you'll see in the blue on your screen, the capabilities are setting direction, strategically aligning decisions with vision, values, and evidence, taking action to implement decisions, assessing and evaluating. So as Ardene mentioned, this is where the evidence-based practice falls, because regardless of your title and regardless of your role, there are results you need to achieve. And this is how you do them. These are the 4 capabilities. And then for each of these capabilities, there's going to be behaviors that tell you what it looks like, for example, to set direction as point of care, or also known as frontline. I like the term point of care better, but then there's a set of behaviors for point of care, there's a set of behaviors for managers, for senior leaders, as well as executives. The personal processes, this is where, this is the most control you have over leading yourself and engaging with others. So under lead self, the 4 domains are self-awareness, managing yourself, developing yourself, and demonstrating character. And this is going to look different depending on your level of leadership. And just an example, so self-awareness. So when we get into the behaviors, I have them here in front of me. So a frontline leader for self-awareness demonstrates an understanding of their own role and responsibilities, demonstrates awareness of their own strengths and limitations, with other behaviors listed there. And then when I flip over to the executive level leaders, what does self-awareness look like? It's role modeling the organization's core values, sharing assumptions when making decisions, and demonstrating a personal style of excellence that inspires others. So you can see how these are really behavioral based. They're not prescriptive. It doesn't tell you how to role model the organization's core values. It doesn't tell you how to demonstrate an understanding, but it tells you that you need to. And that's where our development services come in, is how are you going to perform these behaviors in practice and build on your strengths and use your strengths to fill the gap between opportunities. So engage others. Fostering the development of others, contributing to the creation of healthy organizations, communicating effectively, and building teams. So those are the 4 capabilities, and again, the behaviors are under each one of those. And then we've got developing coalitions. These are the strategic processes and systems transformation. And again, sets of behaviors for all of those. And just as a side note, these behaviors are what are really dug into with the LEADS 360 assessment, which some of you might have heard about. So as LEADS has evolved, it wasn't initially planned to be a change model, but what people have been using as they have adopted the framework within their organization, within their practice, is that they're using it to guide change. And the next slide here. So in any change, you're in a current state, and regardless of what that change is, there's a future state that you need to achieve. And that's the achieving results piece of the LEADS framework. There's engaging others, developing coalitions, and these are the relationship domains that you need to be aware of and work within to achieve change. And then there's leading yourself and systems transformation. Those are the change dynamics. Those are what is guiding your change. So you've got personal processes and strategic processes. And just an example of that is Children's Hospital of Eastern Ontario was working with 2 hospitals in Toronto, I believe it was Markham Stouffville and Sick Kids, to work together to provide a shared service. So the very first meeting of that transition team to plan, they were told that they needed to change. They needed to amalgamate. They needed to provide a shared service. So they planned that very first meeting of the transition team based within the LEAD framework. How are we going to lead ourselves through this transition? How are we going to engage with others? Ultimately, what are the results? What on the other end, what's it going to look like? Who do we need to work with, developing coalitions, and ultimately the system transformation, system improvement piece. So why are we doing this change? And the gentleman I was speaking to mentioned that they felt as a group that using leads to frame that very first session saved them about 2 to 3 months worth of work. And it improved their relationship within the transition team. So we did a 2-year study on the impact of leads. It was a postdoctoral research study through Royal Roads University. We looked at 6 organizations that had adopted leads and were at different levels of, or different stages of their adoption journey. And they found that there was impact on individuals, so it improved engagement, efficiency, effectiveness, and whatnot. People had this better sense of what their role was within the organization, and they had a better sense of what their leadership style was. And then with the impact on the organization itself was this framing of common tasks, goals, projects, changes. So you use the LEAD framework to guide the work that you're doing. And there was a cultural shift within organizations. So there was an impact on the culture when people started speaking that LEADS language. LEADS is mentioned within Accreditation Canada as a leadership standard. It's based on current literature, best practice, and a systematic review of existing frameworks. And actually LEADS, Accreditation Canada uses LEADS internally as well. So why it works? It's simple. It's easy to remember. You take it with you regardless of your role. It's based in evidence. It's a common language. And we find that because that LEA part of the framework really applies to all leadership frameworks, somebody adopting LEADS, you're not starting fresh. You're not starting with something new, one more thing you have to do. It's like, okay, let's take a look at what you've already done. Frame it within LEADS, and that can help identify where you need to go and what other skills you need to develop, because perhaps you've done a lot on leading yourself, but maybe you need to work on the developing coalitions or the system transformation skills and behaviors. So it really helps guide development that way. And I think the uptake across Canada has reflected that it's, you know, you're building on what's already been done. You're not starting over. So looking at who is using LEADS across Canada, as I mentioned, Accreditation Canada. Now, I'm not going to read all of the names to you. I'll pull up the slides, but I'll point out a few. The Salvation Army is one that's of interest because it's moving into social services as well. I'm in Hamilton tomorrow actually presenting to the Good Shepherd Centers group in Hamilton. So we're seeing this sort of broadening of out of acute care into community care, into public health, and you'll see where that's evolved through these slides. So in British Columbia, it's used as a leadership framework for their health leadership development and engagement collaborative, but also it's used within all health authorities, and it's also trickling out into long-term care, such as Menno Place, and there's another one not mentioned there, Lewis Briar, and those are long-term care service providers. In Alberta, we started with Alberta Health Services, moving into long-term care, the Alberta College of Family Physicians, Bethany Care Society, and we just had the Alberta College of Licensed Practical Nurses is working with us to bring in LEADS as well. And that's brand new, and I haven't had a chance to update my slide on that. So as some of you may know, Saskatchewan's combining into one health authority. So they are using LEADS to guide their transition, and they're very actively connected with us in leadership development. Manitoba is broadly used across the province. I want to talk about the Community Health Ontario Leadership Program. So this is funded by the Ministry of Health and Long-Term Care in Ontario. We just got this, and we're bringing LEADS to the Family Health Teams of Ontario, Community Health Centres of Ontario, CMHA Ontario branches, Addictions Mental Health Ontario, as well as Ontario Community Support Agencies Association. So 800 members across Ontario are going to be trained in LEADS, which is very exciting for us. Public Health Ontario is using the framework. Amongst community care access centers, they no longer exist, but we're moving into the LHINs who were recommended to use leads for their transition as well as their new managers. So it is broadly being used across Ontario in different hospitals. Got the North Bay Parry Sound District Health Unit, the Family Health Network, and then you'll see at the end here, Municipality of York, their finance department is, that's a start of the public sector that I mentioned. So in Quebec, moving into Quebec, Horizon Health in New Brunswick, Health PEI, shared services so all of Newfoundland, the 4 health authorities there, and then the Nova Scotia Health Authority, they're all using leads. So when I first met Ardene, we were on a panel with Dr. Gregory Taylor, who's no longer the Chief Public Health Officer, but at the time we were on this panel. It was a lovely weekend in Banff for a health, I can't remember, it was through the University of Alberta. And his comment on the use of leads is that the uptake of leads across Canada has been amazing. This will allow health system leaders to share a common language when leading system change for improvement. So talking a little bit about theory, we're looking at transformational change in the health system. So moving from a hierarchy to flattening out that hierarchy, systems thinking, working collaboratively. Leads as a common language is promoting this transformational change. And it's making lots of big leaps forward versus baby steps. It's a distributed leadership model. So like I said, it's flattening out that hierarchy. And when you think of the shift in our workforce, we're well along our way to having millennials being the majority of, I think the date is 2023, where the majority will be millennials. And you know, there's the misconception. I was at a talk about an expert on this. The misconception is that millennials are very, you know, for lack of a better word, lazy, and they're entitled, and there's all these different profiles, but actually the majority of millennials are empowered. They're very encouraged, and they are coming into the workforce with this vision of they're going to change things. They're going to make a difference, and they're going to make things better. So as leaders, leaders need to know how to work with that, with that attitude, with that grasping onto that energy, and distributing leadership roles so that you can capture that and really change the system. Adaptive leadership. We live in a transformation is, change is common. Change is the one thing we can count on in healthcare. So being able to adapt and hoist your sail and capture the winds of change and not let it put you off the rails and keep moving forward. So you need to have those skills to be adaptive. And then authentic. More than ever, people are looking for leaders who are real, who are transparent, and are themselves. They make mistakes. They may not know everything about everything, and that's okay. And that's how you capture what you're doing and make the difference. So you're going from a paradigm shift from that knight in shining armor, one person who's responsible for everything, to capturing that momentum. And a critical mass of competent leaders who take turns leading and following. So there's lots of skills in there in knowing when and how to do that. So LEADS is being used as a change model, a generic capabilities model, but also a cultural alignment and reinforcement tool. So LEADS is being integrated into performance systems, into development plans. It really is becoming embedded within health organizations across Canada. When you're looking at maturity models, having that, this is a bit of an older slide, but it helps organizations think about how they want to develop their leaders. Do you want to have a plan, or are you going to do bits and pieces here and there? And that's where LEADS, helps guide that plan in terms of identifying the gaps. That you've done lots of lead self, but maybe you need to work on achieve results, et cetera, et cetera. So leadership development, 3 levels within the individual. So fulfilling your own potential, defining the art of your own leadership. Organizational, creating that leading organization and an organization of leaders. And then collectively, building a successful sustainable health system, which is that common goal we all have. So when you're bringing in leads, there's 4 phases that we typically look at: building an internal sustainability of the framework so that there's a cultural shift. Leads Canada is not looking at building dependence. We're nonprofit. We're here for that system transformation and improvement piece. So we work at building internal sustainability through our programming and licensing and whatnot. So there's various models of how we do that. So that is it from me, and I believe I am going to flip it over to Ruth, if that's right.
Yep, that's right. Thanks.
Okay, thanks.
And thank you, Ardene. And we've had a couple of questions, or a few questions that have come in, and I'm just going to read them and then have our speakers respond to the questions. So the first one we will look at is, does the SCAN or core competencies include data and reality of Quebec and literature in French? And maybe, Ardene, you could speak to that.
Yes, thanks, Ruth. Excellent question. And I'm sorry, I should have mentioned this at the beginning. Yes, we got reasonably good participation from Quebec on the online survey, which went out in both English and French. The online webinar focus groups were done in both English and in French, not bilingual. There was English ones and French ones. And the competencies and the full document that talks about the competencies is available in both English and French. I am primarily Anglophone, but I had French colleagues on the academic partner team. So we were able to access literature also in French and in Spanish. So I hope that answers your question.
Thanks, Ardene. And we have another question that came in for nurses that are not in public health, interested in those other community health nurses who are not in public health and find the competencies, whether they're transferable or not, and promoting them with community health nurses in other areas like home health, primary health care nurses. So are they transferable? Maybe, Ardene, you could respond to that?
Yeah, I'd be happy to. That's a very interesting question, and I don't think it's been tested out yet as to how it's being uptaken by others other than the public health nurses. However, what I can say is that we defined public health when we did our literature search to include home health, health promotion, and community-based practice from a wide range of disciplines. So I believe the competencies should be reasonably transferable. And here's where I think LEADS itself can be helpful in drilling down to specific job roles, employment settings, and levels of care. This is a really good collaboration between the two competencies and capabilities that I think can be useful in the future. And I think, Ruth, we should refer this question to the Community Health Nursing Leadership Institute for follow-up. They would be the ones who could exercise leadership, pardon the pun, in answering that question.
Good idea, Ardene, and as the chair, I will certainly bring that forward. So that's great. So we have another question here, and I think this will give an opportunity for Brenda to respond. Is there a tool to guide the use of leads with individual professional development planning?
Yes, there is. Short answer, long answer. So there's 2 tools. There's the Leads 360 assessment that looks at the behaviors. What it does is everybody you're working with, online, anonymous, provides answers based on the lead's behaviors. A report is then generated, and we have one of our leads coaches would then do a debriefing, and flowing from that debrief comes a leadership development plan. Those plans are often integrated into performance systems, whatever they look like, but they are for development purposes. And on a smaller scale, we have a lead self-assessment available through our website that allows you to do some personal reflection on the behaviors, and there is a summary at the end that provides you some direction as far as development goes.
Great. Thanks.
Yeah.
Brenda. And we have another question for you. How do you become a member of Leads Canada? And the person is from BC.
Perfect. So we have an online community for practice, and so within that community for practice, the high level membership is free. It's available for everyone. It's moderated, so we have a leads coach and facilitator, Bruce McLeod, that offers webinars and facilitates conversations and posts resources, and that's called the Lead Leader. That's that Lead Leader membership. And if you want to email me, and or maybe I'm not sure how to get my email address out there, but I welcome your emails, and I'll for sure get you hooked up to that community for practice if you're interested.
Wonderful. Thank you. Now I have another question for Ardene. The comment is, I'm confused between management and leadership concepts. How are nurses providing direct service to patients in the community, not a manager, supposed to work at building coalitions and transforming systems? These actions seem to be reserved to managers. Is leadership reserved to managers?
No, leadership is definitely not reserved for managers. And that is the issue that we found throughout doing the environmental scan, is the conflation of the two terms. Managers can definitely be leaders, but so can people at, as Brenda said, point of care. How you build coalitions at point of care might be family-centered, is a coalition. Maybe you're dealing with somebody who requires social services, so you're meeting other point of care providers at that level, and you're developing coalitions to improve care to the patient. In terms of systems transformation, I think that might be a little bit more difficult, but it includes knowing how to translate knowledge into practice and how to guide change. It's how to be innovative and creative where you are in the organization, whether it's at point of care, whether it's as a supervisor or as an educator, or whatever your job role is. And Leads has done a really good job of leveling, if you like, each of those domains for frontline providers, supervisors, senior managers, etc. So maybe Brenda, you want to add something to that?
Sure, thank you. I've pulled out the behaviors for the framework just to give you some examples. So, in terms of developing and absolutely, I agree with Ardene in that anybody can be a leader, and the whole idea behind the LEADS framework is that you're a leader regardless of title. And that's where we're going to get that groundswell of change in the health system in Canada, is when we have everybody seeing their potential impact and leadership and system improvement. So one of the capabilities for developing coalitions is purposefully building partnerships and networks to create results. An example of point of care leaders is behaviors for that would be identifying stakeholders integral to achieving improved outcomes, maintaining a network of key contacts, both internal and external to the organization, actively consulting with experts, specialists, and others to learn different perspectives. So that's developing coalitions examples, and there's similar ones for systems transformation. So there certainly are some, some roles at point of care, and that's a great question. So thank you for that.
Good, and we have another question for you, Brenda. If Hlth is being used across the country by health and social sectors, is there a risk in public health having their own modified framework?
That's a really good question. And I'd love to hear Ardene's thought on this. And I think that, I think this is, in my mind, the start of the conversation on how we can work together and have that shared language and awareness of what's going on, just so that it is common language. Ardene, what do you think?
Well, I absolutely agree that if we're speaking about leadership using a common language, it's going to make public health more accessible in terms of understanding what public and population health does by people who are in other parts of the health system and in other parts of society. I think it's early days. I think we're just beginning. We're starting to develop a strong relationship with leads. Also, there's relationships being built between the Community Health Nurses of Canada and the other disciplines. And I think that what we're going to see is less of a risk and more of opportunity to co-develop something that is going to be helpful not only to public health, but to the wider sector, not only to organizations, but to professionals within those organizations, and eventually lead to a culture change about what health means in Canada to Canadians. So I think we're really early days of some very exciting times.
Great, thank you. And we have actually a response from somebody in the audience to that question as well. And the comment is, system transformation leadership at the staff level in public health can come through working with other organizations/systems such as school boards or municipal council. Involvement with your professional association such as CHNC provides another avenue for this leadership. So those are just some comments somebody in the audience has made as well. So we have just probably one last question that we can ask, and there was a question about when the third webinar is in February. We haven't got a confirmed date, but a message will be going out to CHNC members to inform them when the next CNA webinar is related to this, but also CNA website has a list of it as well. So the one question I have of Ardene is, what did you mean by the gendered nature of public health when you noted that in the competencies?
Yeah, that came up in the literature review. Gender was almost completely absent in the leadership literature, and our academic team thought that there's a need to better understand the gendered nature of public health in order to be successful as leaders. And what I mean by that, when we looked at the samples for our online survey and focus group webinars, we noted that women outnumbered men by a factor of 3 to 1. Considering the disciplines in public health nursing, considering the disciplines overall, public health nursing has more women than men, but public health inspection, for example, men outnumber women. So gender's never really received a very serious attention in terms of organizational change in the literature. So if we're going to promote leadership in public health competencies, and a majority of frontline nurses are women, what does this mean in terms of organizational change, engagement, and reduction of inequities? Will it be, do we have or will we create a culturally safe environment in order to do business differently in public health? It was well beyond the scope of the scan to answer those questions, but I think it was important that we draw attention to gender. And the other thing I think it's important to draw attention to is the fact that the competencies don't address conflict in any way, shape, or form. And I think we can learn from leads that it's important to note that we not only have to deal with getting along with everybody all the time, but sometimes we have to recognize and generate conflict in order to generate change. So that's what the literature review came up with.
Thanks, Ardene, and thank you, Brenda. We have reached our time that we need to close. I know there's been a few other questions that people have raised, and what we'll do is take note of all these questions, and we'll work out a mechanism to be able to respond to them. So I'm going to pass this now over to our web coordinator, Leah, and she's going to have some questions here that we would like you to complete.
Thank you so much, Ardene, Brenda, and Ruth. We do have some questions for you now, just two questions that I'll bring up. So the first one is, how likely are you to use the information provided in this webinar in your day-to-day work? And the second question is just to get an idea of the number of people who attended the webinar who maybe hadn't registered. So I'll leave these open for a few minutes, or just probably a minute, until we get some responses in, and then we'll close them down. So it looks like a lot of people found the information provided really useful in their day-to-day work, which is great. That's definitely the goal of the webinars. So I'll leave it open for a couple seconds longer, and then we'll just continue wrapping up the webinar today. Okay, thank you very much. So I know one of the presenters referenced email addresses, so we actually have the email addresses for the three presenters today. So if you do need to contact them, feel free to email them. And to access the webinar, so we post all of our webinars on YouTube on CNA's Progress and Practice webinar channel. So all of the leadership webinars and all of our past webinars in English and French are available on the channel for you to view after. It will probably be posted in a few days. If you would like to download your certificate of participation, you can find it in the Files pod under the presentation. And there's also, you can download the slides for the webinar today. So CNA's biennial convention is in Ottawa this year in June. So if you'd like to register, there's more information on our website. And as one of the presenters mentioned, we have the next leadership webinar is coming up this Thursday, Applying a Growth Mindset to Public Health Leadership Competencies, and that will be from 12 to 1 on the January 25th. So thank you all so much. Thank you, Ardene, Brenda, and Ruth for your presentation today, and thank you everybody who attended. I hope that the session stimulated your thinking around nursing practice. And this concludes our webinar today, so thank you very much. Goodbye.